Ladies and gentlemen, dear colleagues, I would like to welcome all of you to the Sanofi Enzyme-sponsored virtual symposium at APAACI 2021. Our subject will be clinical implication of our evolving understanding of type 2 inflammation as a driver of disease. You are hearing my introduction, and just let me go next slide. This is the introduction. Oh, I'm trying to move the next slide. It's not moving. My name is Dermatology. I am a university professor at the Institute and Comprehensive Center for Inflammation Medicine at the University of Lübeck in Germany. And I'm very pleased to have with us Professor Enrico Heffler from Humanitas Clinical and Research Hospital in Milan, Italy. These are my disclosures. And I'm just leading you to the agenda. After this short introduction, we'll have a first talk from Professor Enrico Heffler on asthma, nasal polyps, and the spectrum of type 2 inflammatory diseases. And then I will follow for the next 20-minute taping into type 2 inflammation, understanding the mechanism driving atopic dermatitis. Then we'll have a short discussion, and then I will close the meeting. Objective of this meeting is to explore the role of the type 2 inflammation in a range of atopic diseases, including asthma, chronic sinusitis with nasal polyps, and atopic dermatitis. Of course, it's also very important to understand how can we implicate all this understanding that we are gaining from this meeting. How can we clinically implement, and also what kind of a potential we'll have for interdisciplinary management of these diseases. This will be something that we'll discuss together. But nevertheless, I will give through to my colleague, Professor Dr. Enrico Heffler, asthma, nasal polyposis, and the spectrum of the type 2 inflammatory diseases. Enrico?
Thank you very much, Diamant, for the kind introduction. Thank you very much, of course, to Sanofi Genzyme for the invitation to this very interesting symposium. Well, I will talk to you about asthma as a polyposis within the context of the type 2 inflammation. In order to do it, I would like to start, well, of course, these are my disclosures. I would like to start with discussing with you, presenting with you a real clinical case that we followed in the last few years. Well, this is a patient, a male patient, 32-year-old when we visit this patient, with a history of asthma. Actually, the patient was 33-year-old, but the diagnosis of asthma was made when he was a 32-year-old, so it was a late onset asthma. At that time of the asthma diagnosis, we suspected also a potential occupational exposure, as he was a baker, but actually I can anticipate to you that the suspect was not confirmed at all. The patient was a former smoker, and he also had as comorbidity nasal polyposis that actually had an onset almost at the same time of asthma, so just few years before. What is quite interesting looking at the comorbidities is that this is a patient with several, despite the fact that he's a young patient, there's a patient with several other comorbidities that are potentially linked to the use, to the overuse of oral corticosteroids, such as osteoporosis, glaucoma, obesity, arterial hypertension. Other important information about this patient is the patient that with a previous history of atopic dermatitis in the childhood. So we already mentioned in a single patient the 3 diseases we are talking about, and this is a real patient. He also had an acute asthma and urticaria, so almost an anaphylaxis, let's say, after intaking of aspirin a couple of years before. So defining this patient as very probably having an aspirin triad, so a Vidal triad, so the combination of asthma as a polyposis and hypersensitivity to non-steroidal anti-inflammatory drugs, but well, actually it tolerates paracetamol. So the patient was seen at our outpatient clinic, already treated with very high levels of treatment, because it was treated with a high dose of inhaled corticosteroids plus LABA, in this case budesonide and formoterol. an anti-leukotriene, montelukast, a LAMA, tiotropium bromide, and also maintenance oral corticosteroids, 12.5 milligrams of prednisone per day. So, and despite all these very relevant treatments, the patient had a completely uncontrolled asthma, because in the previous year he experienced 3 exacerbations, 2 of them required emergency department visit, and 1 of them also hospitalization. And anyway, several oral corticosteroids burst in addition to the maintenance oral treatment, oral corticosteroids treatment. Looking at the biomarkers of these patients, despite the use of oral corticosteroids, we can see slightly elevated FeNO, eosinophils that were, let's say, anyway present, 150, and IG that were elevated. This patient was resulted then negative both to skin prick test and specific IG, including flowers, so excluding, ruling out the diagnosis of Baker asthma that was suspected at the beginning. And as expected from the clinical history described before, the control of asthma was really poor, with an asthma control test of 9. Lung function was also very compromised, an FEV1 of 63% before bronchodilation, and also the bronchodilation was not effective in this patient in relieving the normal lung function. And this patient was also affected by, as we said before, nasal polyposis, and with a very severe nasal polyposis, because despite oral corticosteroids treatment, the patient had a nasal polyp score of 5. That means that there were large polyps in both nostrils, and a compromised quality of life related to nasal polyposis assessed by the SNOT-22 questionnaire. So it was a very, very severe patient. Well, this patient was, we decided together with the patient to start the treatment with dupilumab, anti-IL-4/13, and what we achieved was that after 3 months, already after 3 months, we achieved the complete control of asthma, so with an ACT passing from 9 to 24. A reduction, a significant reduction in the use of oral corticosteroids from 12.5 to 5 milligrams per day of prednisone, and a very rapid reduction also in the nasal polyps score. So a great effect on the nasal polyp outcome, together with a reduction in FeNO, which is, we will see later on, a good biomarker of local airway inflammation. Eosinophils were not completely reduced, but we have to say that oral corticosteroids tends to mask high levels of oral corticosteroids. Therefore, it is possible that the baseline eosinophils were actually much more higher if the patient was not taking oral corticosteroids. After 12 months of treatment, the situation was even better, with normalization of eosinophils and FeNO, with almost disappearing of nasal polyps, and keeping the asthma control, and also a perfect lung function. And this was achieved by reducing and by eliminating totally the use of oral corticosteroids. So it is absolutely a great effect that was actually mirrored by the fact that the patient never experienced any more exacerbations or the need of use of oral corticosteroids as a burst, as a short courses. So this was a very a patient in which dupilumab was really, really effective and changed the life of this patient. Well, I mentioned and described this patient because this is a typical patient with a very strong type 2 inflammation. And would like to tell you something more in deep about type 2 inflammation and the role of type 2 inflammation in both asthma and nasal polyposis. Well, type 2 inflammation is mainly characterized by an epithelial barrier dysfunction. We will see more details in few seconds. and this barrier dysfunction interacts with environmental factors and also genetic predisposition in determining the increase of production by several subsets of cells of some cytokines that are actually signing the type 2 inflammation itself, and mainly IL-4, interleukin-4, interleukin-13, that we will see in a few seconds, really drives the type 2 inflammation, but also other cytokines, IL-31, which has been described mainly in atopic dermatitis, but also there are some data on asthma and respiratory disease, and IL-5 that is crucial for the maturation of eosinophils. And these cytokines interact with several immune cells, determining the consequence, the pathophysiological and the clinical consequence that lead to the severity of the disease in these patients. These cytokines and the type 2 inflammation is actually crucial and central in the large majority of patients with asthma, mainly patients with severe asthma, but not only, because the large majority of patients with nasal polyposis also, and other diseases such as the Sumter triad, so the non-steroidal anti-inflammatory drug exacerbated respiratory disease, or allergic rhinitis, but also some other organs can be really affected by this type of inflammation. The skin, first of all, with atopic dermatitis as a let's say a good example of a type 2 inflammatory disease, but not only, also gastrointestinal tract, for example, with the eosinophilic esophagitis, which is a strong type 2 inflammation. Staying more in details in asthma, the type 2 inflammation that we described, and we will describe it much more in details in few seconds, has really several consequences. Under the pathophysiological consequences, the type 2 inflammation is mediating some of the pivotal characteristics of asthma, such as the airway hyperresponsiveness, which is crucial for all the patients with asthma and also responsible for the let's say the easiness for which the patient goes on exacerbations. But also airway remodeling. And this is very crucial because this increases the severity and let's say, led the disease to be even more severe during the time. So that is absolutely important, but also mucosal overproduction and goblet cell hyperplasia, for example. The clinical consequence is to have the typical symptoms of asthma, so wheezing, shortness of breath, chest tightness, coughing, but also, and much more probably relevant than the symptoms, having persistent obstruction, airway obstruction, and very frequent asthma exacerbation. So you can really understand that the type 2 inflammation is central for all the features that characterizes patients with asthma. So let's go more in details on what type 2 inflammation is characterized in asthma. So I mentioned before that at the base of type 2 inflammation, there's an epithelial barrier dysfunction. In fact, the epithelium, the respiratory epithelium in this case, is not functioning in a proper way, is not able to really have a good, let's say, relationship between the external factors and the inflammatory cells. In fact, several potential triggers, such as allergens, viruses, bacteria, irritants, pollutants, many potential triggers induce the epithelial cell, the respiratory epithelial cell themselves to produce cytokines. These cytokines are called alarmins, mainly TSLP, IL-25, IL-33, and these cytokines are inducing and activating T helper 2 cells, and also another subset which is called innate lymphoid cells too, to produce the central cytokines for type 2 inflammation that we already mentioned before, IL-4, IL-13, and IL-5. I think it's important to highlight the attention on the fact that it is not only T helper 2 cells, but also innate lymphoid cells too, because the the ILC2 actually are cells that have very similar phenotypic profile to the T helper 2 cells, but their activation is independent from an antigenic mechanism, so an allergenic mechanism or viruses. So they can really be activated directly by a link with the epithelium. So the overproduction of IL-4, IL-13, and IL-5 have several consequences, because IL-4, for example, is able to induce the B cell class switching towards the production of IgE, so of immunoglobulin E, and therefore the consequence is an increase in production of a specific and total IgE, and we know that the IgE are able to be linked to effector cells such as basophils and mast cells, and inducing their degranulation, and their degranulation is crucial for the symptoms, also for clinical consequence. This is one of the important role of IL-4, but actually IL-4 is also contributing directly to the eosinophils trafficking to the tissues and to the tissue remodeling, for example, by means of increasing subepithelial fibrosis. Interleukin 13 is really coordinating all the effects of the type 2 inflammation, but it's very strongly devoted to let's say, determining all the mechanism that are related to airway remodeling, such as the barrier disruption, the goblet cell hyperplasia and mucus hyperproduction, the smooth muscle proliferation and contractility, and the tissue remodeling. So you can really see that IL-4 and IL-13 are really, really central. IL-5 actually is much more on the eosinophils life cycle, as the activation and the maturation of eosinophils is strictly dependent on IL-5, and it is contributing together with IL-4 and IL-13 to the trafficking to the tissues of these cells. So the final and the clinical consequence is that we have patients with impaired lung function, with frequent exacerbations, frequent having the asthma symptoms, and therefore finally having a poor quality of life. So we have seen that asthma pathogenesis is strictly linked to type 2 inflammation, but actually there are other type 2 inflammatory respiratory diseases, such as chronic rhinosinusitis with nasal polyps, non-steroidal anti-inflammatory drugs, exacerbated respiratory disease, and allergic rhinitis. And actually, all these three are strictly correlated and very frequently common comorbidities of patients with asthma, and mainly of patients with severe asthma. We know, for example, that about 40-45% of patients with severe asthma have concomitant nasal polyposis. About 7 to 10% of patients have the aspirin triad, and the large majority of patients also have allergic rhinitis. So it is important when we evaluate a patient, when we want to treat a patient, to consider the coexistence of these comorbidities. We say that the asthma, the type 2 asthma, is characterized by type 2 inflammation, but actually this is actually an endotype. So it is a mechanism of action, an immunological mechanism of action in this case, characterizing patients with asthma, with the type 2 asthma as it's called. But actually this can be reflected in several different phenotypes, so clinical presentations, such as, for example, the allergic severe asthma, in which we may expect also to find elevated IgE and not only possibly other biomarkers, such as, for example, FeNO. Or on the other side, eosinophilic but not allergic asthma, that is characterized by a strong eosinophilic inflammation, important inflammation, also local inflammation mediated by FeNO, but not allergy and no evidence of increased IgE. And also some mixed phenotypes in which we can have both eosinophilic and allergic components. You have seen in the previous slide that I already mentioned some biomarkers: eosinophils, IgE, FeNO. Well, this is very relevant because when we talk about an endotype, like the type 2 inflammation in severe asthma, we need to be able to have surrogate biomarkers to define this inflammation. And actually, these three biomarkers seems to be the easiest one to be used. And actually, we will see later on, they can be really helpful also in choosing the treatment for these patients, because we know that type 2 inflammation is characterized by an increase in eosinophilia. It is characterized, as we've seen before, by an increase of IgE, and it is characterized also by the increase of FeNO, also in production of XL nitric oxide. It is actually strictly dependent on the IL-13 pathway. So we can also have, let's say, patients in which may have a strong effect on XL nitric oxide because the IL-13 pathway is very represented, but less eosinophils, or vice versa also. So looking at these biomarkers, we know, and we are quite commonly using, I think, blood eosinophils as non-invasive biomarker. We know that the maturation of biomarker of eosinophils is mediated mainly by IL-5, but the trafficking to the tissues, and so to the lung or to the upper airways, is strictly dependent on the activation of IL-4 and IL-13. And so, if we have, mature eosinophils themselves, if they are not able to reach the tissues, they will not be able to make damage at tissue levels. While it is the combination of maturation and trafficking that makes eosinophils really damaging the local tissues. So in this case, for example, the lung. And we know, in fact, that the higher is the number of eosinophils, and the higher is the probability of having exacerbations, but also the higher is the levels of eosinophils, the higher is the probability to have a response to steroids from one side and also to biologics. So it can be used also as a prognostic factor. XL nitric oxide, so fractionally XL nitric oxide, FeNO, it is a very useful, in my opinion, non-invasive biomarkers, because it reflects actually a different aspect. It reflects a very local inflammation, which is dependent, as we said before, from the IL-4 and IL-13 mechanism, and not directly IL-5. So keep in mind this, because it's useful, really useful. So in most of the patients with asthma, with severe asthma, actually we have all the three biomarkers elevated, or at least one of these biomarkers elevated. So it is important. The key message of this slide is please always use possibly all the three biomarkers to characterize your patients, because you can really have patients with very high levels of FeNO, but maybe low levels of eosinophils. And well, these are patients with a strong type 2 inflammation, despite the fact that the eosinophils are not so high. All these biomarkers can be used, as we said, to define the patient that can be eligible for all the biologics we have, from the anti-IgE, anti-IL-5, IL-5 receptor, and IL-4 receptor, so dupilumab in this case. These are the biologics that we have available. So anti-IL-4 receptor alpha, which is very effective, we've seen in a few seconds, in patients, mainly in patients with increased biomarkers, increased eosinophils and or FeNO. anti-IL-5 that are for which we can have patients eligible if they have increased the eosinophils, and the anti-IgE for which we have eligibility dependent on the levels of IgE. Well, dupilumab, anti-IL-4 receptor alpha, so blocking together IL-4 and IL-13, demonstrated in clinical trial, and now there are also some real-life experiences already available, that is effective, really effective in those patients with an increased eosinophils and or increased FeNO. And in these patients is able to reduce the exacerbations, to improve lung function, and reduce the need of use of oral corticosteroids. Paralizumab, so anti-IL-5 receptor alpha, for example, demonstrated again that the usefulness of measuring the biomarker, because only patients with an increased level of biomarkers, in this case more than 300 eosinophils per microliter, are able to really respond to this treatment. While IG, for the anti-IgE, we do not have many biomarkers that have been used, at least not directly, but anyway, it does demonstrated to reduce exacerbation and improve lung function, and there are some post-hoc analysis that confirms that the increase of FeNO and eosinophils are important biomarkers to define the patients who are responsive. From the safety point of view, is absolutely important to say that all these biologics are very, very safe under the clinical point of view. Nasal polyposis, we mentioned before, it's a common disease. It's a common type 2 disease. The prevalence is probably underestimated because there are no proper epidemiological studies. But anyway, it's a disease characterized by a strong clinical burden in terms of quality of life impairment, in terms of other comorbidities, in terms of reduction of smell, which is bothering the patients, and in terms of treatment burden, such as, for example, the need of surgery and the need of use of oral corticosteroids. Very briefly, again, in nasal polyposis, the role of type 2 inflammation is crucial. We have eosinophils increased. We have the IL-4 and IL-13 mediated mechanisms, and therefore very similar mechanism together compared with those with asthma. And that is the why we have again an epithelial barrier dysfunction and increasing the same mediators we have seen before. So this clinical picture is very similar to what we've seen in asthma. The inflammation is the same. I hope that to convince you that type 2 inflammation is really central in respiratory disease. And now I pass the stage to my friend Diamond for the atopic dermatitis point of view.
Thank you very much, Enrico. You convinced me. I don't know how is the audience. We cannot see it, but for sure you have convinced me. I would need to have the presenter to be a presenter. Tom, can you help me? Now I think it's the case. Wonderful. Let me see. Of course, I think that's what matters in patient with atopic dermatitis. Atopic dermatitis itself, it is a very heterogeneous disease. Clinically, it differs from patient to patient. It differs from continent to continent, in Asian, in African, American, in a patient who are coming from a different world. It looks like the ethnic background and genetic background, it plays a very important role. We see also within the same patient differences. For example, it depends if it's in infancy, in childhood, or even in adulthood. We see also within the same patient, some patches look like more like contact dermatitis. Some of them, they are lichenificate. So it means it's really a very heterogeneous clinical presentation of the disease. How can we distinguish the different diseases that occur in dermatology? Usually we try to separate them in 3 different immune response types. Today we are discussing the type 2 inflammation, and we do see that Th2 cells, but also innate lymphoid cells eosinophils and mast cells are playing a very important role. You see the key cytokines, and Enrico have also discussed them in asthma and also polyposis nasi in rhinoconjunctivitis with nasal polyps very clearly, the role of IL-4, 5, 13, and 31. And we also know that intracellular calcineurin pathway, but also the JAK-STAT pathways are very important. But just for us, for a better understanding of all that we know, normally our immune system, especially the type 2 immune response, is there to protect us from the parasites. But in case that we have immune responsive that, for example, are dysregulated, they can contribute to diseases. So we may get diseases like atopic dermatitis, asthma, and other type 2 inflammation. And the type 3 is not well recognized in dermatology, but this is what is responsible for psoriasis and psoriatic arthritis. And the type 1 is more for rheumatoid arthritis and also other diseases. So finally, we are trying to understand better the type 2 inflammation in dermatology, and especially in patients who are having atopic dermatitis. And as I mentioned, we do see that if we take the serum of the patient with atopic dermatitis, we do see that the vast majority of these patients, they show type 2 cytokines and chemokine. For example, IL-22, chemokine 17, IL-13 is well expressed, but also other chemokines that are really there, which are driven mainly by the type 2 inflammation. We do see that it is not a pure type 2 inflammation, especially in adults. There may be also a mixture of Th1 and even a Th17. However, that what drives the disease, it is still the type 2 inflammation in patients with atopic dermatitis. And we have a dilemma in dermatology. What is atopic dermatitis? In the past, there were two different theories. Atopic dermatitis is disease which is coming from the barrier. This is for sure impaired skin barrier in patients with atopic dermatitis, which is allowing that in environmental factors which are normally harmful, and also microorganisms, irritants, allergens, whatever, and they can penetrate through the skin, and they may irritate the skin or may provoke our immune system toward a reaction. Or the other way around, it is probably not the physical barrier which is important, but the immune dysregulation is leading that the epidermal barrier is dysregulated. That means the adaptive immunity and innate immunity, our immune system is leading to the transepidermal water loss, that the barrier is not functioning very good. And this is leading to the disease, which is called atopic dermatitis. However, once we are looking to the disease atopic dermatitis, I think that what really matters, I'm trying to move my slide. Yes, it is also to understand better how the disease itself, it is change in understanding of the disease. I'm trying to move somehow, it's going back and forward. Can I have the next slide? Because it's not moving. Tom, can you help me? Good. I'm trying to move my next slide, please. Yeah, good. What I think is also very important is either too fast or too slow. Let me do it very slowly, and I will go and wait until the next slide will change. Now it looks like that it's going too fast. Sorry, can we go back? Let me go back with my slides. Let me go back with my slides, please. I'm trying to go back with my slides, and it looks like now it's working. Now it's working. Please don't change anything. Let me move with my slide. Let me the cursor do. Jan, please allow me. Good. Not back. Now, please stay here and don't change them. Let me move. No. I think I have a problem with the slides. Can you please go to my first slide, if possible? If not, let me move my slides myself, okay? Because this is something which was not my part. I'm now there. Please don't move the slides. Let me move the slides. And I will do slowly. Exactly. This was heterogeneous disease. The three major types of the cell-mediated immune response. Our immune system, we discussed this one. We have discussed the cytokines. We have also discussed the role of epidermal barrier disruption. And also, this is what I will like to share with you. The healthy skin and the non-lesional skin, they differ. In patients with atopic dermatitis, we do not have the same constitution. If you look at the uninvolved skin, this skin is not normal, because in the non-lesional skin, we do see the reduced microbial diversity. We see a lot of so-called alarmins, which do stimulate our innate immune system. And we have innate lymphoid cells of type 2, which are driving the type 2 inflammation in the non-lesional skin. Once we have the acute lesion, this looks like a contact dermatitis. We don't see inflammation in that level, like, for example, in a lichenification. But in acute lesion, that what is driving the disease is the type 2 inflammation, and mainly IL-4 and 13. While we are having a chronic lesion, in the chronic lesion that what you see on the top of the right, this could be a lichenification, and there is a mixture. There is also part of IL-17. It's a part of the Th1, and it's part also or more looking like a psoriasis lesion, and this is shown here as a lichenification. But itch is what is aggravating disease, and in some of the patient, you may have also secondary bacterial inflammation and infection, like methosing and crusting in this case. I think that what we are learning, it is the role of IL-13 and also IL-4, especially toward of so-called memory Th2 cells. IL-4 and 13 is playing a very important role also in the B cells. We do see, once we are treating this, that IgE is going down. And we have learned there are so many factors and so many places where IL-4 and 13 are playing a very important role. For example, in the inflammatory trafficking of the different cytokines, and especially in the itch and scratch cycles, and of course, finally, to the improvement of the barrier. And that's what matters, I think, itch and scratch circles in our daily practice. But if we look to the pillars of the pathophysiology, we can one-to-one switch them to that what we want to achieve in the patient. First, on the left, we have to improve the skin barrier. We have knowledge that not everything in patient with atopic dermatitis in the epidermal barrier is driven by the filaggrin mutation. In many countries, filaggrin mutation is not playing an important role. But we do see that in patient, we have natural moisturizing factor and also other intracellular lipids, conified envelopes, etc. They are playing a very important role on understanding of the skin barrier. Improvement of the skin barrier is a goal of the treatment. But at the same time, we have to understand how can we learn from the inflammation and control inflammation from IL-4 and 13, and also how this can have implication on improving the skin barrier. And therefore, the next pillar of the treatment management, it is anti-inflammatory treatment. The third, very crucial pillar, it is the improvement of the itch. Today, we know atopic dermatitis and itch in atopic dermatitis, this is not histamine driven. If you give antihistamines to your patient, they will have no improvement, because the acute one, we thought it is due to alarmins, and the chronic itch. And the chronic itch, it is IL-31 driven. And just recently, we have understanding IL-4 and also 13 are having a direct effect on itch. H1 and H4 receptor are having a very minimal result. And this is something that we are understanding from the daily practice and from the clinical trials. And once you think, oh, we know everything, and just recently it was shown that the basophils emerge as the key effector cells in the setting of atopic dermatitis associated inflammation. They are very important in acute itch. So today we have a good understanding. Itch is not itch. We have the acute itch. We have the chronic itch. In both of them, the role of IL-4 is very crucial. The role of IL-13 is also very important. So we are understanding how can we regulate inflammation in general, but itch and also epidermal barrier at the same time. We have a different phenotype. And as I mentioned, in different countries, we have also a different genetic background, but we have also disease which phenotypically looks different. However, wherever we are, if we look to Asian patient, African American, or even pediatric one, that what is predominant is the type 2 inflammation in all of them. In some of them, for example, African American or pediatric, we don't see the influence of Th1. Therefore, the skin is not lichenificate, like, for example, in a patient who are European American. We are trying to understand the role of the type 2 inflammation also from a different clinical phenotype. And this is very important, learning more. How can we learn from the jivas? How can we learn from the genetic background of the patient? How can we find the subsets of the phenotype and bring them together with the genetic background of this patient, and finally to go toward the personalized medicine? This is something that we'll discuss later on, but this is also leading to more targeted treatment in a drug discovery. The intention are going in this direction, trying to find out genetic and also to find out more the phenotype changes in this patient, and also trying to match them. How can we match them? By building some endotype. For example, in atopic dermatitis, if we cluster all this information, then we come to the understanding that type 2 inflammation in all these clusters is very crucial. But in some of them, we have more inflammation, type 2 inflammation. In some of them, we have higher, more itch. In some of them, we have also a lower LANTAS and the lower VEGF expression. So our understanding is that role of the different type cytokines and disease severity may aggravate and may change. So we are trying to find from the phenotype and the genotype to try to find out which are the endotype of the disease. Unfortunately, we don't have a biomarker like our colleagues in pulmonology. Therefore, we must have the surrogate marker. But what is interesting, there is a subtype of the patient who have asthma, rhinitis, and the infancy onset. It looks like this is the original cohort. And we do see that adult onset or puberty onset is not always correlating with a certain cluster. Just giving you some ideas, some flavor of that, what we are going to do in the near future in order to find out how can we distinguish one type from the other type. But that what matters, it is if you look in the role of IL-13 and especially of the type 2 inflammation, normal cytokine subset development from infancy toward the adulthood. It is that it is a very tiny influence of the cytokine subset development in human. However, in atopic dermatitis subset, if you concentrate on IL-13, you see this is a huge impact. That means that type 2 inflammation in atopic dermatitis is playing a very crucial role. And learning from that is, of course, implication, how can we develop new treatment option? We have topicals, which are effective, used for a more limited form of the disease. Phototherapy was used in the past. It's not practical, and it's not treatment option for a long-term management. The systemic treatment existing in the past were not really matching the expectation of the physician and also of the patient. And finally, with the first biologics like dupilumab and tralokinumab, we passed toward a more targeted treatment. And just recently, JAK inhibitors have opened the door also for another group of the patient where we'll be able to manage with a different systemic treatment that we are having. And if we ask our patient, what are our problems? Our problems is that one third of the patient are claiming for poor effectiveness. Is not only the poor adherence, not only adverse events, But in some patients, we may even have a remission. So I think this is what we are aiming for, especially patients with a moderate to severe atopic dermatitis. These are the patients on the high need. And one of this high unmet need was covered by the matching treatment option that we are having nowadays, targeting the type 2 cytokines with dupilumab, which blocks IL-4 receptor alpha, tralokinumab, which blocks IL-13, and also lebrikizumab, which also blocks the IL-13, similar pathway of both of them. And finally, with nemolizumab, which blocks IL-31, which is one of the most important itch-associated cytokines. So we are learning in atopic dermatitis, more targeted therapies are available. Dupilumab and tralokinumab are approved in Europe, and tralokinumab is not approved in the US. Lebrikizumab is under development, and nemolizumab has approval in different countries, but not in Europe. I think it's more in Asia and Japan. If you look now, what can we offer to our patient nowadays? Not the short term. You know the data. The data is phenomenal, excellent. But also in the long-term run. If you take the patient, the responders, and this is the vast majority of the patient with dupilumab, and we follow them for 1 year, 2 years, 3 years, what can we see? What can we expect? Almost all of them, they respond with EASI 50, means 50% improvement. 94% of them with at least 75% improvement, and roughly 85% of the patient have at least 90% improvement. This is a very high bar. If you look, for example, how it is with itch in the pivotal trials, which were usually designed for 16 weeks, and the patient are switching to the open label, and we follow this patient for a long period of time. And after 3 years, we realize that the patient can maintain this treatment response. Furthermore, in some of the patients, we have increase of the improvement of itch, which was measured with a numeric rating scale. And if they have more than 4 points improvement, this means this is meaningful. This is the minimal clinical important difference in this patient. And from the efficacy point of view, it's very good, but also safety is very crucial. In dupilumab, it is also very important to understand that safety is that what really is different from all other treatment options we have. There are very few severe adverse events, and that what pop up as more specific, it is conjunctivitis, which is occurring more frequently with dupilumab than with any other treatment option that we are having. It can come until 20% of the patient. However, 95% of this patient have a mild to moderate, and in a very few cases, it is necessary to stop the treatment with dupilumab. And in vast majority of the cases, we are able to manage this in our daily practice. Moving further, we thought with IL-13, we'll have a different treatment option. We'll probably have also better response, but it's not true. With tralokinumab, less modest treatment response, results are still good. In the long-term management, IL-13 is a valid target. We have an improvement of EASI 75. There are signs and symptoms of atopic dermatitis, and we see roughly 80% of the patient can maintain or even increase this treatment response in the responder from the primary studies. And I think this is problematic. These are the data which I'm presenting now from a long-term studies. All these responders, if they take them, they can even improve the itch. And this is what I'm showing also here with tralokinumab. Also, nemolizumab, which is an IL-31 inhibitor, has shown a very good data, especially in improving the itch. These are the phase 3 data from the Japanese trial. In Europe, we think that 60 milligram is probably not adequate, that we need a higher dosage, and the studies are ongoing. And I think nemolizumab will have also the chance, especially in the patient where itch is predominant, where the redness is not as much on the top as, for example, the itch. And finally, my last part, I will cover the JAK inhibitor, intracellularly. You are aware that in atopic dermatitis, intracellularly, the signal is mediated by the JAK pathway. And the JAK pathway is now a target also for atopic dermatitis, especially the JAK1 seems to be the best target for atopic dermatitis. Also, we know that the JAKs are involved in the different pathways, and they may also have with them a risk that it is very important for the safety profile. And I think that what is also shown, baricitinib, 2 and 4 milligram are approved. They are very good in improving the itch. Probably one of the modest from them among the JAK inhibitor, EASI-75, is maintaining in the responders. We take the responder, they can maintain this treatment response. Interesting for us in dermatology, it is the safety profile. It is a typical safety profile for the JAKs, where we have a higher risk of serious infection, higher risk of herpes zoster, especially in the Asian population. However, that's what we have seen in rheumatology, we don't see in dermatology. Patients with atopic dermatitis do not show the safety profile of the patient in rheumatology. And this is probably a positive aspect of the safety. And the JAKs itself, they have this safety signal. And from the data that we have seen, that they are very effective, especially with very fast onset of action. Upadacitinib in head-to-head was superior to dupilumab regarding the EASI-75 and also improving the itch, and especially the first 2 to 4 weeks. After 4 weeks, there was a flattening of the treatment response. And finally, what was interesting to observe that dupilumab is improving by the time, is not acting very fast as upadacitinib. And finally, after 24 weeks, there is an only numerical difference, there's no statistical difference anymore between the JAK inhibitor and dupilumab, showing that dupilumab and also IL-4, 13 and 13 in general will have a place in the future, especially in the long-term management of the patient with atopic dermatitis. And if you compare the safety profile in the population in dermatology with atopic dermatitis, usually the young population, you will see minimal differences, which are numerical. The study was not done to see statistical differences in safety profile, more zoster, more serious infection compared to dupilumab. At the other side, more conjunctivitis with dupilumab compared to upadacitinib. I think this is a very important once we are trying and learning how can we implement this in our daily practice and how can we learn from efficacy, but also from the safety profile of our patient. And with this, I'm coming to my last slide. We don't have one size fits all in atopic dermatitis. We have heterogeneous disease with a very heterogeneous genetic background, with comorbidities like asthma, or like rhinoconjunctivitis with nasal polyp, and also the others. And I think in the future, this is the ideal place for the precision medicine. We will move toward the systemic biology to learn more. How can we implement all these knowledges that we are having from genetic background, from metabolome, from environment, from transcriptomic, from epigenome, from microbiome? And that's what really matters. It is how can we learn from the others, from asthma, allergic rhinitis, food allergy, and also the others. And I think I will stop here, and I would like to thank you very much for your attention. And I will invite my colleague Enrico to discuss with me. Enrico?
Hello. Yeah, here again. Great.
How do you like the PMI?
No, I mean, it was absolutely an interesting presentation. I mean, what I can say is that in patients with atopic dermatitis, the situation is probably even more complex than in patients with asthma and nasal polyposis, but it is very similar. The fact that we really have to move from phenotyping the patient to the endotyping the patient, so knowing the immunological mechanisms and trying to target the immunological mechanism. Yeah. This is probably the real way to really treat our patients.
Yeah, I think you are right. You know, we are looking, for example, we thought patients who have a severe asthma and patients who have severe atopic dermatitis, they may match, but it's not the case. We have a patient who have endotype, which is more type 2, and then not mandatory have a severe asthma. And I think it's opposite also in your setting that you see patient with a severe asthma, but not mandatory in a severe atopic dermatitis. I think they are coexisting together, and the type 2 inflammation differs in organ by organ. It differs in asthma, it differs in atopic dermatitis. I don't know, Enrico, if you agree.
Yeah, I totally agree. Also, the data from real life. I mean, I have in mind the Italian Severe Asthma Network in Italy, which is the registry for severe asthma. I mean, the atopic dermatitis is one of the comorbidity that we describe in our patients with severe asthma, but it's absolutely not the most common one, and also generally not very severe. While on the other hand, we have a very relevant, strict relationship between asthma and nasal polyposis. So probably the different organs, as you say, that can be affected in some patients at the same time in many organs, and it's fine. In many other patients, probably they really have a more heterogeneous situation. Anyway, when we have a patient with type 2 inflammation, we may expect the presence of comorbidities that can be related. Asthma and nasal polyposis is the best example. They often go together. Severe asthma and nasal polyposis very often go together. And what is amazing is that when you really are able to treat at the same time severe asthma and nasal polyposis, for example, with one single biologic drug, you really obtain wonderful results in both asthma outcomes and nasal polyposis. And you really, I mean, from the doctor's point of view, but I think also from the patient's point of view, this is a great success because you are pointing to one disease and achieving the results in two diseases. Well, wonderful.
One of your colleagues, Enrico, one of your colleagues is calling this collateral efficacy. So collateral efficacy. So you hit with one stone, two birds. And I think this is also the beauty of interaction between the derms and also pulmonologists and also otorhinolaryngologists, where we are learning how can we help to each other, how can we understand better, but how can we match the diseases in order with one single treatment to manage both of them. It's the same with us. And we always think, come on, the asthma is not so severe because we see a mild asthma, but the patient are coming and they have a nasal polyposis and they can smell everything. And they tell me, forget the skin. I am more interested. I can smell. Oh, how beautiful the word is, huh?
Yeah, that's it. And I think actually there's another very important link that is very common for all the type 2 inflammatory disease. And this I think is similar really from asthma, nasal polyposis, atopic dermatitis, eosinophilic esophagitis, and so on. That is the overuse of oral corticosteroids. Yeah. We investigated a lot in the respiratory fields. I think, I suppose, I'm not aware about that. I suppose that also for atopic dermatitis is a big problem, and type 2 targeted biologics are probably a good way to really eliminate the use of oral corticosteroids, and therefore reducing the consequence of these in
Enrico, may I ask you a question? So IL-4 receptor alpha is effective in asthma, but not IL-13. So it is interesting. So lebrikizumab failed. And what do you think? What is the aim? What is the difference? Why IL-4 receptor alpha? Is it IL-4 or it's 13?
Well, I do not have the final answer to this.
I'm sorry that I asked this tricky question, but we are in a big meeting.
I can say that, my opinion is not only my opinion, but it is that probably the clinical trials done with anti-IL-13, so lebrikizumab in that case, were probably not perfectly designed because we're not selecting the patients according to the phenotypes and to the endotypes. This is exactly what we learned about using biologics in our disease. We can do the similar example of what happened with anti-IL-5, mepolizumab, that was investigated in a large population of asthmatics with no effect, but it was confirmed to have been very effective in patients with
You
selected.
select. Yeah.
Exactly. And the lebrikizumab probably in asthma failed to do this. So
We need precision medicine. Yeah. And what do you think about the JAK inhibitors? We have them in dermatology. It's a benefit and risk assessment, but they have no approval, let's say, for the asthma. Is this a disadvantage because we don't see that asthma is affected with a JAK inhibitor? Will be a differentiating factor or not while we are selecting treatment option?
Yeah, again, no final answer to this question. Let's say that it is interesting to see the indirect experience you have on the asthma side in patients treated with JAK inhibitors for atopic dermatitis, but probably more direct data would be needed in order to understand. So, but so far, I mean, I'm not aware about direct treatment, direct trial. I do not have the final answer.
I thank you very much, Enrico. Ladies and gentlemen, dear colleagues, I hope that you loved this Italian-German co-production. It means they are meeting somewhere in the middle, in the Switzerland. So yeah, exactly 1 hour that we started the meeting. I would like to close the meeting. First, I think it was a very interesting one. We have learned the type 2 inflammation from a different perspective. We have seen that a different drug may have a different role in the diseases. So within a pointing and focusing on IL-4 and 13 inhibition, probably as a very important in the different diseases of atopic diseases like asthma, but also atopic dermatitis, learning that this knowledge that we are having, how can we implement tomorrow in a daily practice? How can this also mirror in our treatment decision? And furthermore, how can we learn more? How can we manage these difficult diseases also in the future? I would like to thank Sanofi Genzyme for supporting and you, Enrico, for this fantastic talk and also for this interaction. To you all, I wish a very successful meeting. Thank you very much and stay safe.